Bismillahirrahmanirrahim. Assalamu alaikum. Greetings and namaste. I welcome you all to World Patient Safety's webinar for the Asian region. That includes the EMRO region as well. So you already know that the World Patient Safety Day is celebrated all over the world on 17th of September. And the objectives of the World Patient Safety Day are to increase public awareness and engagement, enhance global understanding, and work towards global solidarity and action by all stakeholders to improve patient safety. So in 2019, the first World Patient Safety Day was organized and held and celebrated, and patients and other healthcare providers from all over the world basically, participated in organizing a great campaign on patient safety. So the World Patients Alliance is also organizing a range of activities, a complete campaign on World Patient Safety Day this year. So we are organizing a range of activity that includes these regional webinars. So we've already held webinars for the American PAHO region, for the European region. This one is for the Asian region, and then tomorrow we are going to hold our African region webinar. In addition to that, we are also organizing a big range of activities all over the world through our member organizations. So we are organizing seminars, walks, community sessions, online events. So a range of events we are organizing, and we anticipate organizing more than 700 events all over the world during this World Patient Safety Day campaign. We have a very distinguished group of speakers for today's webinar, and I will introduce them to you in a few moments' time. But after the presentations, we will have our panel discussion and question and answer session. So please hold back your questions, but if you have any questions, you can always write in the chat box, and we'll definitely ask those questions to our distinguished speakers. So before we start our first presentation, I would like to request all of you to please keep your mics off so that there are no disruptions during our webinars. So let me first introduce myself. My name is Hussain Jafri. I am the chair-elect of World Patients Alliance. I'm also the Secretary General of Alzheimer's Pakistan. So I'm basically based in Pakistan. I'm also the Vice Chair of the Advisory Group of World Health Organization's Patient for Patient Safety Program. And I'm also the Provincial Focal Person on Patient Safety and Quality in Punjab, Pakistan. So first of all, I will be talking about, giving you an introduction on World Patients Alliance. So let me begin by introducing the World Patient Alliance. We are an umbrella organizations or patients organizations around the world, and our mission is to be the global voice of patients working towards patient empowerment and engagement, and improve access to innovative treatment and patient-centered healthcare throughout the world. And our vision is that the patients will have access to safe, high quality and affordable healthcare everywhere in the world. So as I mentioned earlier, our mission is to be the global patient voice. We want patients, representatives, and community to engage with other stakeholders to highlight the importance of patient engagement and work towards patient-centered healthcare. I'm extremely happy to inform you that the World Patient Alliance, in just over 1 year's time period, has become the largest umbrella patients organization in the world that's working across disease areas in all regions of the world. So this means, we are not disease specific patient organization, but we are working across disease areas in all regions of the world. We currently have 318 patient organizations as our members, and span over 106 countries of the world. Our board is also representative of, it has global representation. We have our chair, Andrew Spiegel. He's the executive director of Global Cancer Association from US. He's based in USA. Then I'm the chair-elect. I'm based in Pakistan. Then we have our secretary, Penny Cohen. She belongs to American Chronic Pain Association. Then Jolanta Belinska is our treasurer. She is the founder of the Polish Patient Safety Foundation. And we have Carla Ruiz de Castilla. She is based in Peru, and she, is from Esperanza. And then, last but not the least, we have Regina Kamoga. She is from Uganda, and she is the executive director of Chain Uganda. These are the principles of World Patients Alliance. I'm not going to go through these principles one by one, but you can see these are 9 principles, and I'll just name them out. It's access to healthcare, patient-centered healthcare, financial hardship, empowered patients, patient safety and quality, patients education and information, partnership and collaboration, patient engagement, and no discrimination. You can go onto World Patient Alliance website and look at these principles in detail with more information. So at the World Patient Alliance, we have a patient safety and quality committee. 4 of us, that includes Helen Haskell, Hussain Jafri, myself, Jolanta Belinska, and Regina Kamoga. We are members of this Patient Safety Committee. If any one of you would like to join the working of the committee, become part of this committee, please do write us, email us, and we will definitely make you a part of our team. Now coming to the WHO Patient Safety Program, in 2002, the world nations through World Health Assembly passed as a resolution and urged the member states to pay the closest possible attention to patient safety. So, as a result of this resolution in 2004, the World Health Organization's Patient Safety Program was established. It basically aims to coordinate, disseminate, and accelerate improvements in patient safety worldwide. There are different strands in WHO Patients for Patient Safety Program. One of the very important strand is Patient for Patient Safety. This basically comprises of patients advocates from all over the world, and these advocates are working together to make a difference globally. So all the work that's now currently being done at the WHO, efforts are being made that input from patients are taken in all of WHO's work. So at the moment, all the Patients for Patient Safety champions, as we call them, these are the people who have undergone a training, and because of that, they become Patients for Patient Safety champions. So they are involved in a number of activities globally. The WHO's Patients Safety Program has also an initiative called Global Patient Safety Challenges. These are the sort of initiatives that the big campaign that WHO has run for patients' safety. The first campaign was on clean care is safe care, and I'm sure you would have seen in hospitals in your countries where hand hygiene and hand cleanliness was stressed upon to the healthcare providers. Then after that, the second challenge was working towards safe surgery. The third campaign, which is currently being run at the moment, is 5 moments for medication safety. So this is something that I'm sure you would observe, see in your healthcare facilities, that this campaign is run very successfully all over the world. Then recently, in 2021, during the 74th World Health Assembly, the world nations have approved, Global Patient Safety Action Plan 2021 to 2030. Dr. Monda is going to give a complete presentation on this action plan. It's a very important initiative. And I think one of the most important aspect of this campaign is that the patients and families and patient organizations must be actively involved in the execution, monitoring, and evaluation of the action plan at all levels including local and international levels. So we all hope that this action plan will be implemented in all the countries, and patient representatives will be made part of this action plan. So Dr. Monda will shed more light on this. So coming down to this year's World Patient Safety Day. Safety Day campaign. The theme of this year's campaign is Safe Maternal and Newborn Care. And the slogan is Act Now for Safe and sorry, there are messages coming onto my screen, so I can't really read it properly. So the slogan is Act Now for Safe and Respectful Childbirth. We have a very high maternal and infant mortality rates in some parts of the world. As you can see, around 810 women lose their lives every day because of maternal, complications. These are young women, very healthy women, and they die, in their youth, and the families actually undergo a lot of problems because the mother, the wife, is the pillar of the family, and if you lose a mother or the wife, there are very tragic consequences for the rest of the families. The research shows that if a mother dies, more than 50% of the infants that remain behind also die because the mother is not there to look after them. So in addition to maternal deaths, we also lose about 6,700 newborns every day. Plus there are 5,400 childbirths every day as well. So the tragedy there is basically that these deaths are preventable, and most of these lives can be saved through the provision of safe care. It's just that you need to provide the safe care and access to safe health care that we can really reduce dramatically the number of maternal and child deaths all over the world. So the World Health Organization has devised some key messages on this World Patient Safety Day. So I will go through these messages that I'm sure you would be able to take back to your communities to spread it around. So what can a woman do during and after the pregnancy and delivery? So they should speak to your healthcare worker about how you can reduce safety risk during pregnancy and around the time of childbirth. The woman must be actively involved in their own care as well as their baby's care. They must attend all appointments during pregnancy and after childbirth. They must also communicate openly with the healthcare team and ask questions. And very importantly, they should prepare themselves mentally and physically for childbirth and the first few days after the childbirth. What could families and communities do? They need to speak up for safe and respectful maternal and newborn child. Support your spouse during pregnancy and around the time of childbirth, and speak up for their safe and respectful care during pregnancy and after childbirth. They need to get involved in community initiatives to support mothers, newborns, and health workers, and work actively with policymakers to establish safe maternal and newborn services. So what can healthcare providers do? So they can, build your competencies to provide safe and respectful maternal and newborn care. They should build trust and engage and empower women and strive to make childbirth a positive environment for all women and newborns by providing safe and quality care. Apply all the required safety measures during pregnancy, childbirth, and the immediate postnatal period, such as medication safety, surgical safety, blood safety, radiation safety, medical device safety, sanitation, and infection prevention. And they must also speak to supervisors or colleagues if there are any concerns about maternal and child health. The next message is for the healthcare providers and facility managers. So they must create an enabling environment for safe and respectable maternal and child-born care. They must invest in health worker safety and well-being as well as in their capacity development in healthcare, safe healthcare. They must establish a safety culture in which healthcare workers are not afraid to speak up. Moreover, they should also promote an environment for childbirth that involves women in shared decision making, maintaining their dignity, privacy, and confidentiality, and preventing mistreatment. They must also ensure all births are attended by skilled birth personnel and invest and establish adequate infrastructure to provide safe maternal and child health services. And our last message is for policymakers and managers. Yeah, so they should prioritize safety in maternal and newborn services and act now for safe healthcare systems. They should invest in health system by allocating sufficient resources for equitable access to safe and quality maternal and newborn health services. They need to build a competent and sufficient health workforce supported by a safe and enabling work environment. They must also ensure the establishment of mechanisms to engage women, families, communities, health professional associations, civil society to establish safer maternal and newborn health services. And they should also establish reporting and learning systems to guide improvements in maternal and neonatal care. So these were the key messages for this year's World Patient Safety Day. So let us all work towards ensuring that safe maternal and newborn care, so that no one loses a mother or a child during pregnancy or after childbirth. So this was a brief introduction to World Patients Alliance as well as to World Patient Safety Day. So now, can I have this next slide? Yes. Now we have a very privileged, we are very privileged that to have a very distinguished speakers panel for this webinar. Our first speaker is Dr. Mondar Latif. He is the Regional Advisor at the Health System Development Department and responsible for health care quality and safety program at the WHO EMRO office at Cairo, Egypt. He is also a professor of preventive medicine at the University Hospital of Monastir, Tunisia, and has areas of expertise that cover quality and patient safety improvements, training, research, implementation of QI interventions and assessment, as well as preventive medicines and public health. Dr. Mondar is also a member of Middle East and North Africa JCI Advisory Council, the Advisory Board of the MENA Health Policy Forum, and the JCI's Editorial Advisory Board. Dr. Mondar has a vast experience of working in the area of patient safety and quality at the local, regional, and international levels. He is leading the patient safety and quality initiatives of WHO in the EMRO region. So over to Dr. Mondar for his presentation on WHO Global Patient Safety Action Plan.
I'm delighted to be with you today, and I would like to thank the organizers for giving me this opportunity to share with you this presentation, which is on the Global Patient Safety Action Plan, patient safety as a strategic priority. In this presentation, we will cover a background and context, then we will see the global movement of patient safety, followed by an overview of the Global Patient Safety Action Plan 2021-2030, then the role of WHO in advancing the patient safety agenda, followed by some upscaling actions in order to successfully implement the Global Patient Safety Action Plan, and we will conclude by some take-home messages. Well, I would like to start by highlighting the importance of patient safety as a priority that faces health systems everywhere, regardless of their income status. Second, there is no universal health coverage without safer care. And it is critical for universal health coverage, and universal health coverage without ensuring safer care would be an empty promise. It aims at avoiding harm to those the care is intended and underpins the principle of first do no harm. It is one of the most important components of care delivery, and safety can be considered as the entry point to ensuring quality health care. The burden of unsafe care is particularly very high for low and middle income, as well as fragile, conflict-affected, and vulnerable settings. And some studies that we conducted in the Eastern Mediterranean region have shown that up to 18% of hospital admissions are associated with severe adverse events. So what is the burden of unsafe care on health systems? First of all, in terms of frequency, over 1 in 10 patients continue to be harmed from safety lapses during receiving health care. And globally, unsafe care results in well over 3 million deaths per year. Recent estimates suggest that as many as 4 in 100 people die from unsafe care in low and middle income countries. The burden of harm is estimated as 64 million disability adjusted life years per year, similar to HIV/AIDS. It has a very high preventability, and investment in patient safety offers good returns in terms of reducing the morbidity, reducing the mortality, and also reducing the cost. This shows the global movement of patient safety, and we see that we have different milestones. The World Alliance for Patient Safety that started early in 2004, the World Patient Safety Initiatives, the Global Ministerial Summits on Patient Safety, and the resolution WPA 72.6 on global action on patient safety. At the regional level, and here I refer to the Eastern Mediterranean region, there is a wide array of tools and initiatives that are related to patient safety. And here, very briefly, I can refer to the Patient Safety Friendly Hospital Initiative. And we are now we just published the 3rd edition of the manual. We have also developed a patient safety toolkit that will help teams working on the ground addressing patient safety priority based on the assessment. In addition, we have some advocacy tools such as the brochure. And parallel to this, we have also conducted some work in relation to, for example, the implementation of the patient safety and quality framework. This is an implementation framework that relates to patient safety and quality in extreme adversity. We have also developed a set of 34 indicators, core indicators for quality and patient safety at the primary care level. We have also supported countries, and here we have an example of a country where we supported on the development of a national program for patient and community engagement for safer care. As regards the global movement on patient safety, I wanted to highlight the importance of the global ministerial summits on patient safety. We have had 4 so far. The 2020 was set to be held in Switzerland, but unfortunately it was postponed due to COVID pandemic. I wanted to highlight the importance of the global ministerial summits that have played a key role for the endorsement by member states of the resolution WPA 72.6 on the Global Patient Safety Action Plan. Since then, work has started in consultation with the different stakeholders and actors, and this has led to the Global Patient Safety Action Plan. So what is it, and what is the content of the Global Patient Safety Action Plan, and how to implement the proposed strategies and interventions related to the action plan? So it contains the vision, the mission, and the goals, 4 partners in action, 6 guiding principles, and 7 strategic objectives. First of all, the vision, mission, and goal. So the vision is a world in which no one is harmed in healthcare and every patient receives safe and respectful care every time, everywhere. The mission, drive forward policies and actions based on science, system design, and partnerships to eliminate all sources of avoidable harm and harm to patients and health workers. The goal is to achieve the maximum possible reduction in avoidable harm due to unsafe healthcare globally. Then we have partners in action. We have governments, healthcare facilities and services, stakeholders, and World Health Organization. The guiding principles, we have patients and families and partners, results through collaboration, data to generate learning, safety culture, evidence into improvement, policies and action, scientific expertise, and patient experience. And we have 7 strategic objectives These are policies to eliminate avoidable harm, high reliability systems, safety of clinical processes, patient and family engagement, health workers' education skills and safety, information research and risk management, and synergy partnerships and solidarity. So this gives the framework for action that includes the 7x5 matrix, 7 strategies with 5 actions each, so which gives us 35 interventions in total. This is to highlight the importance of prioritizing these interventions based on the country context and based on the country capacity. So now moving at the country level for the implementation of the global action on patient safety. So this figure shows the different elements that should be considered at both the government level and also at the point of care. At the government level, there is a need for a policy dialogue first, a needs assessment in order to identify the different priorities, and this should lead to the development of a national policy and strategy for patient safety. And this, of course, should include a guidance and implementation or an action plan that will include the specific intervention in relation to the identified priorities with the evaluation in terms of identified information systems that will show us to what extent we are moving with the implementation of the global action at the national level. This in one hand, and in this level we have what we call the upstream interventions that will lead to the policy execution. The upstream interventions include, for example, the leadership, the regulation, the accreditation, the action plan, the safety culture, and the different the prioritization as well. This is on one hand. On the other hand, at the point of care, we need to make sure that we have some key interventions for the implementation of the global action on patient safety. This will include the advocacy, awareness raising of the different stakeholders, including the community, explaining what patient safety is and why is it a priority for both health workers and the public. The resource mobilization, from where are we going to have the needed resources in order to implement the identified priorities. Knowledge generation in terms of building the capacity of the health workers on how to implement the patient safety, what is the patient safety culture, and what is needed in order to implement this successfully. I mean, the support needed by the leadership and the support needed by, in terms of a safety, adopting and fostering a safety culture. The collaboration and cooperation, and here I would like to highlight the important role of the community, the patient representatives, and the families. The implementation, with the implementation, you will have an action plan that can be progressively implemented based on the identified priorities at the operational level. Now, what is the role of WHO in advancing the patient safety agenda? First, the role should refer to WHO's core functions. I mean, the leadership, setting the norms and standards, evidence-based policy options, technical support, shaping research agenda, monitoring the health situation. The role of WHO in advancing the patient safety agenda should also refer to the 13th General Program of Work. And here you have the mission, the strategic priorities, the strategic shifts, and the organizational shifts. The key message from here is that the essence of the 13th General Program of Work is to drive impact in country level. Therefore, the support to countries should be tailored according to their capacity and the maturity of the health system. And here it can range from service delivery, support on service delivery for specific priority, to policy dialogue for the development and the adaptation of their national strategic plan for patient safety. Now, what are the drivers that will scale up the implementation of the global action on patient safety? Here we have first the prioritization. of the interventions. As you have seen, we have 35 interventions. This needs prioritization in order to select those that are most important, those that are most relevant, amenable to interventions, and those that are feasible. The contextualization is very important, and the intervention should be in full alignment with country priorities and capacities. Leave no one behind in terms of ensuring access to safer care for vulnerable populations such as IDPs, migrants, and refugees. Learning systems, these are systems that are able to generate information, collect information, generate knowledge, identifying the gaps, and ensuring that these gaps are addressed. Promoting patient safety, promoting patient and community empowerment and accountability. These are very important. Accountability measures such as feedback, public reporting, participation of the affected population, risk register. All these are elements that will contribute to improving the accountability measures. The integration with health policies and priority programs. Why? Because most of the time patient safety activities are separated from these programs, while the patient safety interventions and principles should be embedded within these priority programs since the design of these programs. Last but not least, COVID-19 pandemic has shown the importance of safety for both patients and health workers, and safety should be considered as a priority, not only for the response and the delivery, but also for the preparation of these interventions. These are additional examples of interventions at the ongoing interventions at the regional level. These include, as you see, the publication of the third edition of the Patient Safety Friendly Hospital Framework, which is like a platform that includes all the interventions based on the evidence, will help teams for the implementation of a patient safety system at the facility level. We have also finalized, and it will be published very soon, the Patient Safety Friendly Primary Care Framework. A technical paper on the role of the primary care to ensure quality and patient safety during pandemics, an online module for the safety in primary care, an online module for patient safety during COVID. And I am happy to inform you that we have developed a set of 22 indicators for health workers' safety. These are being field tested in 4 countries from the region, and the results will be shared very soon with member states. What will be the benefits of these indicators? These can be used for assessing the situation, reporting on the performance with regard to health workers' safety, and also as a tool for improving the situation based on the identified gaps. Now, how can the World Patients Alliance contribute to advancing the patient safety agenda? The World Patients Alliance is a key player in more advocacy for patient safety around the globe, and patients from all the world regions and across all diseases area are invited to speak up for patient safety. Attention should be given to fragile, conflict-affected, and vulnerable settings, and the celebration of the World Patient Safety Day to increase public awareness and engagement, enhance global understanding, and work towards global solidarity and action by all stakeholders to improve patient safety. In summary, these are the take-home messages. I would like to highlight the importance of the heavy burden of unsafe care. This burden is avoidable, is highly preventable, and the investment on patient safety offers good returns. Second, patient safety is critical to achieving universal health coverage. It is the foundation of the health system strengthening and the health system's resilience. Third, member states have committed to invest in patient safety, and we should seize this opportunity in order to work hand in hand with countries for the advancement of the patient safety agenda. 4, the WHO's Global Patient Safety Action Plan provides the pathway to enhance member states' capacities to ensure safer care. And finally, last but not least, support to countries should be tailored based on local context and capacities and priorities. I think I have reached the end of my presentation. I thank you for your attention, and I am happy to respond any questions. Thank you.
Thank you very much, Dr. Munda. I think it was an excellent presentation, very, very informative, and I'm sure there are going to be a lot of questions from people who are listening. But we will just hold on to your questions. We will be asking the questions towards after the presentations are over. So thanks once again to Dr. Munda. Please, if you could wait for some few more minutes until these presentations are over, then we'll have a panel discussion and question and answer session. I'm honored to introduce our next speaker. He is Dr. Abdullah Al-Hassawi. Dr. Abdullah is the former founding Director General of the Saudi Patient Safety Center and Ministry of Health Advisor on Patient Safety in Saudi Arabia. He led the efforts to establishing the Saudi Patient Safety Center as a WHO collaborating center for patient safety policies and strategies. And I must tell you that it is one of the only 5 centers available, all over the world. So we are very privileged to have the center available, present in EMRO office. He is a leading quality and safety consultant and has recently become the Vice President of the Global Sepsis Alliance, as well as an advisor to American Health Information Management Association. He was part of the expert panel on the 3rd Global Patient Safety Challenge of the WHO and chaired the organizing committee for the 4th Global Ministerial Summit on Patient Safety in Jeddah, Saudi Arabia in 2019. He has helped introduce patient safety as a G20 priority in the 2020 G20 of Saudi Arabia. Dr. Abdullah is part of the WHO Global Patient Safety Action Plan Task Force. So over to Dr. Abdullah for your presentation on pandemic and patient safety in the region.
Thank you very much, Dr. Hussain. Thank you all for the nice invitation. So, let me start with the last word that Dr. Hussain mentioned, which is the pandemic. I'm actually going to talk to you about the overlooked pandemic. So it's just a coincidence that today is September 13th, which is the World Sepsis Day. Sepsis kills 11 million people, and as you heard from Dr. Munda, that the estimates for unsafe care are also in the millions. Now, by definition, patient safety is the absence of harm. So that's why I think it's important for us within the patient safety community to make sure that everything that is preventable harm falls under the umbrella of the work to promote patient safety. So again, it just happened to be a coincidence that today is the World Sepsis Day. I think we need to, sepsis is killing 11 million people, and COVID last year killed 2.5 million. COVID has gotten all the attention, but we need to keep in mind that there are overlooked pandemics that are killing more and more people, and we need to make sure that there are no silos in our work to really align with the healthcare system and strengthening. So I'm going to be talking about basically the pandemic and patient safety. So that's the outline of what I'm going to talk about. I'm going to look at the preventable harm, comparing before COVID and during COVID. When we talk about safety during these times, it's important that we don't just focus on the elephant in the room, which is the COVID-19. So we will talk about safety for COVID-19 patients, but safety for non-COVID-19 patients, you will see that the errors of omission are going up, and I hope that after all said and done, we can look at some of the research that shows that actually COVID has killed so many people and has harmed so many people, not by the virus itself, but by basically just being tunnel vision on thinking COVID and basically ignoring everything else. I'm going to mention some of the interventions that we've done in the kingdom during my time in the Canada Patient Safety Center. And again, safety and zero harm, as Dr. Tedros mentioned, no one is safe until everyone is safe, or basically, the safety of patients and the safety of healthcare workers go hand in hand. So just to explain to you the idea behind this graph, this was a graph that I built back in April of last year when I presented this topic before. And if you look at the death from patient safety, or from unsafe care, to be around the 2.6 million, which is the minimum. This is just in low middle income countries. There is, if we do the full study, the unsafe care is causing more than 5 million people. But if we just look at death from unsafe care in low middle income countries, so this is 2.6 million. Now, this would translate into almost 200,000 plus death a month. So this is where the green line is, which is in a non-COVID year. This is how the graph of death from unsafe care would project on a monthly basis. Now, COVID mortality started in January of last year. So this is between January and April. You could see how these two lines are splitting. And again, just keep in mind, this is a very, very conservative estimate of death from unsafe care compared to death from COVID-19. If you add other countries, not just low middle income countries, the graph will, and the lines will split more. So just to kind of reiterate the point that I mentioned, why is patient safety being more challenged during these times? Because patient safety has been having lots of problems throughout the years, but since the start of this pandemic, there has been even more and more problems. And again, our hypothesis here that during a non-COVID year, which is the orange line, compared to during the COVID year, which is the dotted gray line, we believe and evidence will show that harm has gone up. Harm of both, not just the existing harm of commission, but also harm of omission. There are all kinds of different cases from around the globe showing that these problems, and the reason for that is threefold. There are patient factors, so fear of patients going to hospitals and medical centers during COVID-19. There are also healthcare systems factors and the poor readiness of the systems to deal with such a problem. And then there are provider factors. How many hospitals, how many times have every one of you heard, oh, we've got COVID. So we've got COVID, like we're just shutting down the hospital for other patients. What happened to cardiac illnesses? What happened to cancer treatment? What happened to the so many other diseases that we're dealing with? Somehow people kind of just got stuck into you're either COVID or you're not, and if you're not COVID, then you can take basically you can wait. And unfortunately, that is just creating a much bigger problem for healthcare systems to deal with, and a lot of harm for patients, acute and chronic. So again, I don't have to kind of belabor this point, but the stories are from around the globe about the difficulties that patients are facing not from COVID-19, because everyone is just kind of putting that magnifying glass on COVID-19 and it's ignoring everything else to the detriment of the health and wellness and the healthcare systems in general. So again, this is kind of highlights the same point about the patient factors and the systems factors. So that takes me to the second part of my presentation, which is the safety of COVID-19 patients. I happen to be actually a COVID-19 patient. Fortunately, I did not end up in an ICU, but I had the healthcare workers dealing with me, and I've had people with kind of with the same outfit dealing with me. I've had the fear, especially early on. I got COVID in March of last year, so that was during the very early months of COVID, where people were just so scared of what could happen, etc. And I could tell that healthcare workers were concerned to kind of deal with me, not to contract the infection, but also look at these different pictures and just imagine the difficulty of handling patients while you're wearing all these PPEs and the potential harm that could happen out of that. So lots of potential problems for COVID-19 patients. Either people are in whatever kind of setting, but especially in acute care setting. So the safety of non-COVID-19 patients, and this story actually came it was part of the New England Journal of Medicine, I think back in 2020. And the long story short, this is a patient that presented with straightforward acute coronary syndrome, and unfortunately, people were kind of stuck with the thinking COVID. So they overlooked the number one killer, which is cardiac. It's not COVID. Again, the number one killer is cardiac. In every, in most countries, you look at the global burden of disease, they overlooked the number one killer. And what ended up happening, this patient ended up dying from a cardiogenic shock, because physicians in the emergency department, nurses in the emergency department, people in the hospital, just froze, they stopped thinking and they just continued to think that everything is COVID, and they overlooked everything else. So errors of omission, mark my words, errors of omission have gone up, and they will go up more unless we really hit the reset button and try to look at this with more perspective. That yes, we have to deal with COVID, but we cannot freeze out the healthcare systems, and we cannot stop being clinicians, and we cannot stop thinking, how we can help patients. So delaying patient care may burden the already and potentially exhausted healthcare system, as I mentioned. So this is a prioritization. During my time in the Saudi Patient Safety Center, we came up with. We've actually done this in collaboration with more than a dozen of the scientific and medical societies within Saudi, and the whole idea was to have these three categories. So of prioritization: red category, which is emergency cases that need to be addressed within 24 hours. Orange category, these are the urgent and the semi-urgent, which can be dealt with within 1 to 30 days. And yellow category, these are the elective and routine non-urgent cases, which need to be dealt with over 30 days. I think if you have that mindset, and for all specialties, I think what you need to have, if you really want to make sure that you promote safety, if you really want to make sure that, we're talking about the safety of mothers, we're talking about the safety of kids, but it's the safety of all patients. If we want to do that, then you really want to have that risk management program in place. Otherwise, you're going to have more and more stories of the same one that I mentioned, where you have very common disease that are just being ignored because people have in their mind COVID. So last year's theme was health workforce safety is a priority for patient safety. And I don't think that should be just a 1 year's theme. I think we have to have a redefinition of safety that encompasses not just patients, but also healthcare workers. We have to have a redefinition that rather than just saying that patient safety is the absence of harm and one size fits all, we have to, in a way, personalize safety. And the only way we can do that is to co-produce safety. And how we can co-produce safety without making sure that the health workers are safe, because if you're trying to balance the safety of your patients at the detriment of the safety of health workers, I think the end result is not going to be good for neither. So to summarize, I've talked to you about the trajectory of safety during COVID, and I'm making the case, and I hope I can be proven wrong, but I don't think I am. I'm making the case that harm has gone up during COVID. Why? Because of all the reasons I mentioned. Because we stopped thinking as clinicians, and we were frozen, many of us, into COVID, and we lumped everything else as others. So I think we have to hit the reset button, go back and think about common things, and think about how we can have a risk management strategy in place that, yes, addresses COVID, but make sure that we don't overlook cardiac diseases, we don't overlook cancer, we don't overlook pregnant mothers and everything else. Patient safety for COVID-19 patients, I mentioned the challenges. I've had a personal experience. And for the non-COVID patients, again, keep in mind the errors of omission. They will go up. They have gone up, they will go up. Health workforce safety, both the physical and the psychological, is a paramount. We can't have patient safety without health workforce safety, so we have to co-produce that. And I did talk about the prioritization, and you have to have a business continuity plan in place, where if it's COVID this year, last year, maybe in 5 years, it's another pandemic, it's another whatever emergency, we cannot just close hospitals and send people home. We have to have a business continuity plan in place where we address the emergency, but make sure that we also we serve the community. So with that, again, let's break down the silos. I hope that in our discussions with mother and child safety, to talk about the sepsis of neonatal sepsis, maternal sepsis, we should not deal with sepsis as like just one tribe and patient safety as another tribe. That has plagued the healthcare system. We need to break down silos. If we are really true and truthful to saying that patient safety is the absence of harm, then it's the absence of all kinds of harm, absence of preventable harm. I think we should highlight that in our discussions. So thank you very much, and I look forward.
Thank you very much, Dr. Dalella. I think it was an excellent presentation, providing an overview of the patient safety during this pandemic. And we all agree that a lot of patient harm has occurred, much more than what usually happens during this pandemic. And especially the patients, the chronic patients who could not be really offered their routine treatment because of the pressures of the COVID. And not only the patients suffer, but I think the healthcare providers, as you said, they also suffered a lot because of COVID. So thank you very much for an excellent presentation. Now we move on to our next speaker. Let me introduce Dr. J.S. Arora. He is the Secretary General of Thalassemia Welfare Society and Federation of Indian Thalassemia. He is a patient safety champion since 2007, and he is also serving as a member of the advisory group of WHO's Patient for Patient Safety program since the year 2014. Dr. Arora is the founding member of Indian Alliance of Patient Groups, as well as founding trustee of the Genomics and Public Health Foundation. So over to Dr. Arora for your presentation on Global Patient Safety Challenge, Medication Without Harm.
Greetings from New Delhi, India. Today we are discussing Global Patient Safety Challenge, Medication Without Harm. What are the medication errors? Any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of healthcare professional, patient, or consumer can be defined as a medication error. The errors are inevitable and caused largely by weak health systems. The challenge is to reduce their frequency and impact. The global challenges identify patient safety burden that poses a significant risk to health. The challenges aims to encourage and empower patients, their caregivers, and healthcare professionals to take an active role in ensuring safer medication practices, including prescription, preparation, dispensing, administration, and in March 2017, WHO launched the third Global Patient Safety Challenge with the theme of medications without harm. The goal of the challenge was to gain worldwide commitment to reduce severe avoidable medication-associated harm in all countries by 50% over the next 5 years. WHO provides leadership and guidance in collaboration with all stakeholders and experts to develop and implement interventions and tools to reduce risk, improve safety, and facilitate beneficial change. To address the weaknesses in health systems that lead to medication errors resulting in severe harm, it lays out methods to improve the way medicines are prescribed, distributed, and consumed, and increase awareness among patients about the proper use of medication. Partner with countries to disseminate and implement interventions. The four focus areas of the challenge are patient and the public, healthcare professionals, medicines as products, and systems and practices of medication. It has divided into 16 subdomains. There are three prioritized key areas, that is monitoring polypharmacy, reducing harm from high-risk medicines like insulin, opioids, anticoagulants, and antipsychotic drugs, medication safety, and transition care. The objectives are to facilitate the strengthening of systems and practices that can initiate corrective action within countries to decrease avoidable medication harm. The five specific objectives are assess the scope and nature of avoidable harm and strengthen the monitoring system to detect and track the harm. Create a framework for action aimed at patients, health professionals, and countries to facilitate improvements in medication safety practices at all levels. Develop guidance, materials, technologies, and tools to support safer medication use system. Engage key stakeholders, partner, and industry to raise awareness and pursue to improve medication safety. Empower patients, families, and their carers to become actively involved and engaged in treatment decisions and manage their medication. This is the most important. What is the burden of the medication error? Medication errors cause at least one death every day and injure approximately 1.3 billion people annually in US alone. Low and middle income countries show similar trend, and it is double in terms of number of years of healthy life lost. Many countries lack good data, so burden cannot be assessed. Globally, the cost associated with medication error has been estimated at US $42 billion annually. It is almost 1% of total global health expenditure. Some studies have been published. In 1993, Leap, the principal investigator of Harvard study in 1984, published that 180,000 deaths were preventable. In 1999, Institute of Medicine observed that around 44,000 to 98,000 deaths occur annually due to medication error. The 2004 report on inpatients based on 2000-2002 revealed that 575,000 deaths by medical errors occur, that is 195,000 per annum. in 2008, a study on medical beneficiaries revealed that 180,000 deaths occur annually, and if this is extrapolated to all US hospital admissions in 2013, it turns out to be 400,000. Why do medication error occurs? Errors are not result of individual failure, but of a system failure. Administration of medicines in improper dose and beyond scheduled time, administration of duplicate medicine to the patient, incorrect drug selection for a patient due to lack of knowledge of prescribed drug, lack of knowledge of patient details, illegible handwriting, use of verbal orders. These all can cause medication errors. Study was done by tertiary care hospital in Pune in India in February 2017 to 2020 or to analyze the look-alike sound-like drug incidents. There were overall 1,311 errors. 35, that is 2.67%, were Lassa drug incidences, and 23 out of 35 were due to injectables. 68.5% were phonetically sound-like drugs, and 22.85% look like medication containers or packets. In 74.28%, the harm could be averted because it was noticed, the error was noticed at nick of time. There was near miss. No harm occurred in 20% cases. Maybe the substitute may not may be similar, and in 5.7%, the harm was noticed. When it was further analyzed, it was found that most of errors were due to dispensing errors, 45%, and others important were indenting error, 22%, and administration error, 20%. It was good to note that prescribing errors were low, around 2.8% only. What strategies were followed by the Pune Center? They made an identification and color coding of Lassa drugs. For example, look-alike drugs, yellow stickers, and sound-like drugs, pink stickers. Color-coded list was also prepared for the pharmacy nurses and the doctors. Training of all healthcare professionals to handle Lassa drugs. Revision of Lassa drug list annually. Regular audit by clinical pharmacists to verify the implementation. Intelligence institutes said that use of bolded tall men uppercases, like as you've seen in oxycodone, oxycodone, cefazolin, ceftriaxone, can be tried, but these are not feasible as many prescribers have started writing drug names in capital for legibility and clarity. Use of both a brand name and generic name also helps, but it is also difficult when the formulation contains two or more than two ingredients. Another method can be adopted is include purpose of medication on the prescription, like writing the drug is for hypertension, BP, diabetes, etc. Prescribers frequently use some abbreviations. In commonly used abbreviations like U, used for units, but it can be mistaken for say 4U as 40 or 44. So better to use units, full or words, all correctness. IU can be mistaken as intravenous or 10. So there also it is better to use units. OD can be mistaken as 10 days. So it is better to use once a daily or one daily. While prescribing a drug, say 0.5 milligram, it can be mistaken as 5 milligram. Dot may not be understood by the pharmacist. So it should be written as 0.5. Same way, 1.0 can be mistaken as 10 and preferably should be written as 1. I'll give you some common example we see in Lassa drugs. Herbal leukorrhea drug is Lumital and anti-epileptic drug Lumital can be misunderstood at any level. Ubisure is a health supplement while Ubisure F is a medicine for polycystic ovary syndrome. Longifen is an anti-allergic drug and Longifen A is a herbal appetite stimulant. I'll give you some clear example which I faced in my lifetime. That is, I prescribed a resist to a 5-year-old child, 10 ml in a straight dose antiviral drug, but the chemist dispensed as Raggy. Incidentally, lucky that the grandmother of the child brought that 30 ml bottle to me and asked if this is to be given all at a time. I realized that the wrong medicine has been dispensed and harm could be avoided. A drug Oratil which contains cephaloxamine by the same company introduced another drug Oratil LZ with cephaloxamine and linzolid. There, because of the government restrictions, they had to withdraw the combination and they shifted to linzolid only, but they retained the name Oratil LZ. But some prescribers may be prescribing still Oratil LZ, thinking that it contains two antibiotics. Pyrite 2 milligram is a drug for constipation. Pyrite 15 by 2 is for diabetes, which can be easily mistaken. If mistaken, can cause severe hypoglycemia early in the morning to the patient. Patients can use medication app or pill sorter to keep track of medication schedule if the patients are taking many drugs, and this is happening when they have many diseases, comorbid conditions like diabetes, sugar, thyroid. At Thalassemia Center, what we do is we have made a printed prescription with all the important medicine which we prescribe regularly with the formulations curve, dosage, and investigations which is done at what frequency. On the back of it, we have made do's and don'ts for the patients. Patient can read itself at home and understand how disease is to be managed and what medicine to be taken and how medicine to be taken. This can be adopted by many other chronic disorders like thyroid, diabetes, hypertension, and diseases. Steps to prevent medication errors in indoor setup. Always try to see one patient at a time and always call a patient by two identifiers, not just by a single name, and read the prescription label at least 3 times and compare with the medication administration record. Review patient allergies prior to administration and always minimize interruption. Don't interrupt a doctor or a nurse when they're examining or prescribing or dispensing a medicine. Document the prescription, the administration of medicine as soon as it has been given. Other areas where medication error can occur in the hospital setting, patient's current medication list should be visible at a prominent place. Home medicine list should also be there for reference, but the patient was taking medicine at home. Reconcile the medicine, all medicine at the time of discharge. Update patient's medication list to include all medications to be taken after discharge. Include new and continuing medications and previously discontinued home medications that are to be resumed. Communicate to the patient or caregiver discharge instructions. Medications not to be continued should be ideally discarded by the patient. So 6 rights of safe medication administration are: right patient, that is, ask the patient their first and last name, right medication, right dose, right time, right route, and right documentation. It's very important. Document immediately after a medication is administered. Work environment has a major role to play for medication errors. Medication error can be caused by health worker fatigue, which we see recently in COVID era, overcrowding in some general hospitals, staff shortage at again public hospitals, poor training and wrong information being given to patients. It affects prescribing, dispensing, consumption, and monitoring of medication, which can result in severe harm, disability, and even death. The challenge calls on countries to take early priority action to address these key factors. There should be no noise in the area where the patient is examined and no distraction by the patients, caregivers, or by the staff sitting over there. Role of pharmacists. Pharmacists should dispense only as advised, not always try to substitute the drugs. Check if two similar drugs have been prescribed. If there is discrepancy in patient's age, weight, and dose, counter check with prescribing doctor. Prescribing error can be there. Incorrect drug selection based on indications, contraindications, known allergies, existing medication therapy, etc. Dose, quantity, route consultation or instruction by physicians, omission and error. should be discussed with the prescribing physician before dispensing the drug. Patient has a major role to play on the medication safety. Always, whenever you visit a consultant, take one person from your family or friend with you. Prepare a list of your complaints, signs and symptoms and queries before visiting for consultation. Always reveal your all medical history, allergies and medicine, including supplements, before the examination begins. If possible, reconfirm from doctor if you have been dispensed with the right medicine. Self-medication and investigations can lead to complications and wastage of money. Report to your doctor if you develop any unexpected symptoms as early as possible. Ask questions about how to use the medication. And use of two similar drugs or two different brand names can be disastrous. Other things are try not to skip your medication. Inspect medication before leaving pharmacy. Try non-drug options like uh, lifestyle disorders like borderline diabetes, cholesterol, gastritis, etc. Do not put refrigerated medicines in the freezer, which is very common mistake, and always carry refrigerated medicine like insulin with ice pack. Don't give leftover medicine to friends and relatives. A common practice among the patients. Always discard or donate to an institute. Use the same pharmacy because your pharmacist understand your disease, medication, and dosage. Do remind him if your doctor has changed medication or dosage. The take-home message: both health workers and patients can make mistakes that results in severe harm, such as ordering, prescribing, dispensing, preparing, administration, or consuming the wrong medication or the wrong dose at a wrong time. All medication errors are potentially avoidable. Preventing errors and the harm requires putting systems and procedures in place to ensure the right patient receives the right medication at the right dose by the right route at the right time. Thank you.
Very much, Dr. Arora. It was an excellent presentation, and also for providing us, the sort of guideline on how to really reduce these medication errors. So thank you very much. We'll be taking questions after our last presenter. So then we may ask you some more questions related to your presentation. So our last speaker for today's webinar is Manveer Victor. Manveer was a renowned radio DJ in Malaysia when he suffered kidney failure in 2002. His health care experience from diagnosis, 10 years of dialysis, and finally organ transplant motivated him to become an active patient advocate. He became the founding chairman of Patients for Patient Safety in Malaysia, where for over 6 years he has provided consultation to healthcare organizations or integrating patients into their organization. He also sits on the Malaysia's National Patient Safety Council. Manveer is also the advisory group member of WHO's Patients for Patient Safety program. Moreover, he is also a member of British Medical Journal's Patients Advocacy Panel. So over to Manveer for his presentation on role of patients in patient safety.
Hi, my name is Manveer Victor, and I'm the chairman for Patient Safety in Malaysia. I've been the chairman since 2013, right here, and I'm one of the WHO, the World Health Organization, trained patient advocates who are global, who are working in a global nature. And this is a great opportunity and honor for me to be presenting to you guys. I do not want to show you too many things on a slide mechanism at all, but I just want to talk to you all because I think communication is very, very important in healthcare, and it has not been happening as well as it should be. So just to start off, I'm going to go on to the beginning of my story, which happened about 15 plus years ago, when I was fine. I was 35 years old. I was, or so I thought I was pretty okay. And then I started falling a little ill. And from that, I decided to go to a hospital and meet a doctor just to do a simple blood test. And once I had done that, what happened was the doctor who had given me the blood test, said, I have to refer you to another person. So he moved me on to another doctor, a very elderly gentleman who looked extremely experienced. But he looked at me, he looked at the results, and he said, Manvir, it looks like the results are not very good at all. Your kidneys have failed. And then he pointed to a machine that was sitting behind me, and he said, you see that machine? That is a dialysis machine. You need to be on that machine next Monday. And obviously, I was in shock when he told me that. I just sat down, listened to him. I don't know what was going through my mind. And then he looked at me and said, okay, fine. I'll leave you with my nurse. And he got up and he left. That's it. He just got up and he left. Then his nurse came, took me outside to sit down in the waiting room. And something in my mind just clicked. I got up and I left. I absolutely left. I went downstairs. I called another friend of mine who was a doctor. And I told him, this doctor just told me this. I do not know what to do. He sent me to another doctor at another hospital. He recommended me. So I went over, I sat down with that doctor. The doctor said, listen, Manvir, I'm very sorry. I have to ask you to do some more tests. I have to ask you to go for a scan, all these things. But after we've done all these things, later today, I will be able to give you a better answer as to what is wrong with you. So I said, okay, no problem. So I went another blood test, and then I had to go for scans and so on. All this happened in that second hospital. And later in that evening, probably around 4 or 5 o'clock, the doctor called me in. He showed me my test results. He showed me what a normal test result would be like. He showed me a diagram of the size of a kidney, and he showed me the size of my kidney and why it was so small. Then he said, these are the issues here, and it really looks like you need to be on dialysis. But you don't need to be on dialysis next Monday. We can try a little bit of treatment with dieting and so on and see whether we can help you at all. So once the doctor had explained all these things to me very, very simply, I went through some treatment processes with him, and it took about another 3 or 4 months. But after that 3 to 4 months went through, and then he looked at me and he says, listen, you are not getting better, you're just going to get worse. You really need to get a fistula done because eventually soon you're going to need to do dialysis. So I had to go and get my fistula done, and then for 10 years I was on dialysis with the clinic of that second doctor. And he would come and see me, and he would continue the conversations and so on and so forth. But you see the difference between these two doctors that I am just talking to you about. I'm here and I sit and I'm talking to you today because of the second doctor, not the first. The first doctor in Malaysia is very famous, he's very well known, he's extremely experienced, and everyone says, oh, he's a good doctor. He has no bedside manner at all. Oftentimes, I thought to myself, I should have gotten up and slapped him when he told me that first answer. Because I was angry, but because also that after that, he would never, ever again do that to another patient. He thought he knew everything. He thought that the patient is an illness. He's not a person. I'm just going to tell you, you deal with it. Now, in today's world where you look at mental health awareness, you look at depression, you look at all these things that go through, that people go through, I can tell you to a certain degree that I probably have a sort of a PTSD, right? A post-traumatic stress disorder because of that first doctor. But I have to overcome it with my second doctor and subsequent doctors that I meet and I talk to. Now, 10 years later, I met some more doctors, of course, during that process that I was on dialysis. I had undergone a few operations here and there. Uh, but I'm very blessed to meet fantastic doctors who took the time to sit down and explain to me things in a very normal way. What I mean by normal is they understood that I was a patient. They understood that I did not spend 7 years in a medical university learning about these things. I learned it through pain. I learned it through suffering. I learned it through fear. I learned it through not understanding things, but I began to try to understand. And because I was wanting to understand, they would impart to me in that way. So the best doctors I have met, I was not that first doctor. I don't care what the label at the back or the degree at the back of him says. To me, he is a kind of a doctor that I want you guys never to become. Never to become that first doctor. Become the second doctor. Become my transplant doctor. I underwent a transplant. They sat down there painstakingly and explained to me every single part of that procedure. And after that, how I would feel, how I would react to things. But what really happened that made me do what I do today is after that, the transplant, and after that operation, I realized that they knew everything in theory. They didn't know it in practice. They knew it in practice from their point of view. They thought I would feel like this. I didn't. I felt something else. So it was that understanding that I just realized that the doctor, he knows everything in theory. He has studied, he's at the top of his class, he has done this transplant numerous times. The doctors have given the medicine numerous times to numerous patients. But what really happened was me as the patient, I felt differently about it. So after my transplant, which was successful, I went to the doctors and I said, listen, there is a little bit of a disconnect here between what you tell me and what I feel. Can I address this with other patients so that I become an advocate for what you're about to do? And the doctor said, yes. That was how open my transplant doctors were in the hospital Kuala Lumpur, which is one of the premier places in the world to do a transplant. And so I went through that entire process, learning from them what I should talk about, but also understanding that from a patient's point of view, it was very important for them, the patient, to speak to another patient. So I would have, they sent me to speak to next recipients of transplants. So I used to go into the room, and this was like a month, 2 months after my transplant. I would walk in there, very slowly, of course, after my transplant. I'd walk in there very slowly. I'll open the door. I'll talk to them and I say, I'm a patient. I just finished my transplant on June 26th, which was probably a month ago. And I'm standing here in front of you. And the patient's eyes would light up and look at me and says, wow, this guy's fantastic. He had the transplant. So they felt a connection with me immediately. Immediately, they felt a connection. I can look at this guy. The proof is in the pudding. The patient is standing there. Now the patient is telling you, okay, now the doctor told you this, listen to him. The doctor told you that, listen to him. The doctor told you this, listen to him. Now, here's how you practically do what he's just said. His suggestion is you will feel pain. You will feel the pain of the transplant in that area where it is. And so you will have a problem, for instance, very simple things of going to the bathroom, from getting up from your bed itself and just putting your feet down, balancing yourself, you will have that issue. The doctor does not know this. He has never undergone a transplant. So that simple thing of communication from a peer-to-peer point of view with the patients, and we're going there and we're telling them, yes, we know you're afraid. Yes, when you go in, this is exactly what is going to happen. When you go in there, the anesthesiologist is going to come and ask you your weight and double check with your your name, your date of birth, your identification number. All these things are going to be done, and you're in fear. Do not be afraid. Trust them. They are going to understand. They want to make sure that you are the person you're supposed to be. And all this, just taking them through this entire process, one step at a time, the patient is more prepared. And that is what is very important today in healthcare, as we have so much of information available on the internet. People can Google something and that story is there. Is that story true? That story came from millions of miles, from thousands of miles away. You have no way to verify it. But if it is the wrong kind of information, it will breed fear. It will breed fear in the patient, and they will begin to distrust the healthcare practitioner. So it is important for you itself, the healthcare organizations, to have patient involved in every step of the way so that the patient understands what it is that the hospital want, and they are able to communicate it to build confidence and trust with other patients and so on. And from a peer-to-peer point of view, it is better to speak to another patient, to understand another patient, and have your questions asked to these other patients, because the patients know. I know what it feels like to be fearful. I know my hands during those 10 years that I have been on dialysis. I have been poked about 4,000 times. I used to be able to be injected anytime before that. Now I have a fear of needles. I have a fear of needles because I have been poked 4,000 times. Does a doctor know how that feels? I don't think so. So that is the kind of fear that patients go through. It may be unnatural, it may be weird, it may be special, but we have to try to allay that because you guys are doing a great job. The part that you are not doing well enough and can do better is in communication. There are certain things that you can't do, but patients can. So the role of a patient as part of the organization to be able to understand what the other patient is going through. This is what the WHO, with things like, with people like Dr. Hussain, who's part of this as well, is a great chap who understands empathy. He has sympathy for the patient. He is understanding for the patient. And this is what we are trying to inculcate in more of our global members, to be able to go and work with organizations like yours, be at conferences like yours, to speak to people in the industry itself, to be able to equip them to understand that, listen, the patient, me, I am not the illness. I am the person. I have fears, I have dreams, I have ambitions, I have likes, I have dislikes, I have allergies, I have all these things as well. You cannot think of me as a kidney patient only. And the key thing to that is to be able to open yourself up and understand that organizations need to be inclusive. They need to be inclusive of patients because you guys are treating the patients. Do you know what the patients are going through? Not every single time. Here in Malaysia, we're very unique in the sense that since I came out from my transplant, I've had everybody from my uncles and aunts, from my neighbors, people who I didn't even know, who found out that I had gone through this transplant, who are trying to sell me products so that I can be better quicker, which is one of the things that my doctors told me: do not take any other thing. Do not take any third party stuff. You've had the transplant. We are going to make sure that you're fine with this. But everybody else was starting to try to sell me things. That's peer pressure. When family members come and drop something in your house and you say, take that, that's very uniquely Asian. Very uniquely Asian that we've got all these mumbo jumbo solutions, healthcare solutions to us. It doesn't always work. And having the patients around, we understand what my other fellow patient is going through. And therefore, we work on ensuring that that doesn't happen. That's just one of the examples of things that you can do. But the main thing is, of course, include the patient, and that is the important role. The patient advocate needs to be a part of this entire process to take your healthcare to the next level. Thank you very much, and I'm looking forward to questions.
Thank you, Manveer. I think it was enlightening. And thanks for providing and describing the patient journey, in the healthcare. You know, it's important that the healthcare providers and other stakeholders also understand patient's perspective and what a patient basically goes through when they're on a healthcare journey. It also highlighted that what an empowered and engaged patient can achieve, the positive sort of health outcomes that you achieve. So we'll certainly have questions for you as well. So I'm sorry we are running a bit late, a few minutes late. So what we are going to do is we're going to ask one question to each of our speakers, And if there are any other more questions, then you can, send it to us by email, and we can, always get back to you with the answers from our respective speakers. So my first question is to Dr. Mondar from the World Health Organization. Dr. Mondar, if you could, highlight how can patients be involved in global patient safety action plan? I know you highlighted that patients should do advocacy and all that, but how can they really be involved in their countries? Where there are WHO country offices and all the sort of health ministry and everything. So how can they be involved? Is there something that's been kept in the this global patient safety action plan for patients as well?
Thank you. Thank you, Hussain, and thanks again for the invitation. And you are, I think, asking a very interesting question, which is about the role of community and NGOs and what role can be given to them. I think at the different levels of the health system, there is a key role to play by the community, the public, and the advocacy association for patient safety. Let's start by the policy and the national level. For the policy and the national level, the representation from the community, from the NGO is key in order to contribute to the development of the policy, the strategies, and the action plan. At the institutional level, the implementation, we have a key role. And as it was highlighted by the previous speakers, particularly by Mr. Manvir, the role of the community, the patients, is very important. And the experience has shown that great progress could not be achieved without the key participation from the public and from the patients. So at the implementation level, the consultation, the information, the communication, the feedback, so that they can produce the healthcare. They will be co-producers for the healthcare. They can be advocates, and you know that we have, for example, patient safety champions. These are champions that are very active at the operational level, so that they can spread the messages, they can spread the knowledge, they can mediate between the healthcare professionals and the community and the patients. I see the role of the community needs to be further highlighted and further, I think, pushed forward. Over.
Yeah, thank you, Dr. Mondar, for highlighting how can the patients be active in this area. And I would request, because you are really literally would be involved in running this plan, at least on the EMRO region, that if there could be more opportunities provided to the patients at country level. There are some patient advocates who are active at the international or regional level, but there are many more patients that really need right at the grassroots level that need to be involved. So we look forward to your patronage and supporting the patients right at the local level. My next question is to Dr. Arora. Dr. Arora, you may know that there's a lot of big problems regarding the abuse of medicines as well, like overuse of antibiotics. So can you please let us know how can the patient organization, what can the patient organization do to overcome this big problem of over abuse of antibiotics as well as injections?
Yes, you rightly said, Mr. This antimicrobial resistance is very highly prevalent these days in all over the world. Actually, what happens, especially in low-income countries, in high-income, I can say in US, UK, and Europe, they start antibiotic only after going for a culture. But in the low-income countries like India, or you can say Pakistan, Bangladesh, all these countries, there the patient don't wait for the result for the culture. They want immediate result. So at times, what happens? private doctors or small doctors are forced to prescribe antibiotics. I think here the patient has an important role to play. If they have any problem, doctor says that okay, you take. Especially I'm telling the case of diarrhea. In the most of the cases, in the case of diarrhea, you don't require any antibiotic. You just have to give the ORS or simple plenty of fluid and all these things. But if a patient is advised this ORS and only for some dietary supplements, and at that time it is not laid within 2 days or so, he changes doctor regularly. So at the time when he goes to second or third doctor, when he prescribes the medicine, antibiotics, and it is relieved, and the patient thinks that the first doctor was a fool. He has not advised antibiotic, and that is why this second doctor is good. So a patient should trust the doctor. If the doctor is saying, see, the one thing is that every patient should have one family physician. Patient should not go to a super specialist. That's another problem. What we have seen, especially in these countries, what happens if you have a simple headache, if you don't get relief within 2 days or so, you are going to neurophysician, neurosurgeon. If you are just for a simple bony pain, you are going to orthopedic surgeon. So he will advise even MRI, CT scan, all these things. It is not only just overuse of antibiotics, even overuse of investigation as well. So it is increasing the cost of investigation, increasing the cost of antibiotic, and leading to even this antibiotic resistance. So I think here comes the role of both of the patient and the doctor. First of all, the doctor should educate the patient. Yes, this is the course of your disease. This is the prognosis. You are not going to be cured within the 2 days, 3 days. It will take 4 or 5 days. You don't need any antibiotic. You'll be cured after that. And what happens? Another, especially in urine infection, patient has. We ask for urine culture. Patient want to start immediately antibiotics. The moment you start antibiotic, cultures become negative, and then patient to take unnecessary antibiotic, even if it was just of a burning mutation because of other things. So here the patient should have to understand also that if the doctors are advised you don't require antibiotic, or I'll give antibiotic only if you are not cured, then they should take medicine. I think the role of both patient and doctors comes over there. And especially in the second thing I have noticed, especially in the hospital, the moment you enter in the hospital, they immediately start the higher antibiotic. They just start the miraculum resistant antibiotics. So that is another case, especially the nursing homes and hospitals, they are giving higher antibiotics, even if they are not required. So here I will again the roles of patient come first. Patient should have some patience as well. It becomes difficult for a patient to have patience. But if patient maintains some patience and you can say stays with the family physician, he will be cured with you can say less of the medicine, less of the investigation, and less of the cost of the investigation and all this. That's right.
Yeah, thanks, Dr. Arora. I think it's an excellent answer, and it highlights the importance of patient's responsibility as well. We can not only always ask for our rights. I think there are responsibilities as well. So this takes me to Manveer, and building upon this, I would ask Manveer, how can patients be empowered? As Dr. Arora has just said, they need to be empowered to understand the sort of treatment they are taking. They need to be empowered to take part in their healthcare. They need to be empowered to advocate for their cause. They need to be empowered to partner with the healthcare providers. So, what do you think? As your story, we can see that you really were empowered enough, and then that's the reason you really were able to get sort of positive healthcare outcome that you had. So, what do you think? How can patients can empower themselves?
Thank you, Hussain. Can you hear me?
Yeah.
I can hear. Yeah. Okay. Thank you, Hussain. I think very good point the question that you brought up as well. And it's not only about us empowering ourselves. I think a lot of patients go on Google and they look for answers when they don't have a proper communication with their own physicians. So it's actually the physicians that need to also open themselves up. The administration have to have a different sort of a mindset. And one of the things I wanted to share with you guys there is this, that it's probably 3 points that you probably have to do is, number 1 is engage, number 2 is educate, and number 3 is empower. It's only then when we get the correct response from the patients. And what is key about this is, I was just Googling this as well earlier. The world today, as of September, has a population of 7.9 billion people. 7.9 billion people, right? And do you know how many healthcare people there are in the world? According to WHO, there are only 59 million healthcare workers. That's doctors, there is nurses, there's healthcare workers, administrative, everything is 59 million. Now, just to put that in perspective, that is the population of Italy taking care of the entire world. This is not possible without empowering patients. You have to empower your patients. You have to communicate with them, because if you don't, you are not going to be able to reach 7.9 billion people. There's no human way possible other than getting them involved in it, bringing them together with you on the education. That has to be constantly done. And the reason I'm able to do what I do today is speaking to people like you, Dr. Aurora. I know that we are constantly talking to each other and getting different points of view, learning new things. But if that engagement is not there, then healthcare loses out. Because each and every one of these people who are on this webinar right now, you have patients just like me in your country, and you have patients just like me in your clinic, in your hospital. And I'm one of those lucky ones that I'm able to talk to you today because my doctors believed in me. My doctors saw that this guy wants to do something. And so I am not special in the sense that you, in every one of y'all, have that patient who is there. So tomorrow when you go back to the clinic, when you go back to the hospital, look for that patient that is going to do what I do today, and just engage with them, educate them, and empower them, because they will be your powerful tool. I hope I answered your question.
Yeah, I think very well, very good answer, and I think probably people have also learned a lot how to really engage. So this brings us to the end of our webinar today. So we are over time. So I'm grateful to all of you for your patience listening. I'm extremely grateful to the participants for staying up long for the webinar. I'm extremely grateful to our speakers, Dr. Mondal Taib, Dr. Abdulela, Manveer Victor, and Dr. J.S. Arora, for taking time out and enlightening us on this important patient issue. So if there are more questions to our speakers, I would request if you could send us email, and we'll get your answers, and we'll not only send those answers to you, but we'll also put it on our website so that others could also learn from them. The video of this webinar will also be available on our website as well as on our YouTube channel. And last but not least, I would request all the patient advocates, if you're organizing any events during the World Patient Alliance, do let us know, and then we might be able to help you with more sort of information on the event and the sort of materials like social media posts and other things. So we might be able to help you with giving you more projection with your event. So with this, I thank everybody, and since we are already late, I think we must close our webinar. So thanks to everybody. Bye-bye.